All right, well, good afternoon, everyone. It is 2 o'clock, so we'll get started. Welcome to this afternoon's PEAS session around collaborative practice and roles for healthcare providers. I just want to make a notice that we will be recording this presentation in video format. The recording may be used and disclosed by Alberta Health Services for educational purposes and may be further broadcast by Alberta Health Services for other presentations, publications, or promotions. This may include conversion to digital format, storing, and publication on AHS webcasting technology. Before we go any further, I'd like to introduce myself and my co-chairs. The three of us are the co-chairs of the Pediatric Eating and Swallowing Roles and Implementation Working Group. I'm pleased to introduce Vanessa Steinke, who's an Alberta Health Services Senior Project Manager, and she's the lead project manager extraordinaire for the PEAS project. You'll hear from her in a minute. Tricia Miller is a manager of SLP, Audiology, and Children's Allied Health in the South Zone. And my name is Melanie Matisse-Dewar. I'm a unit manager at Alberta Children's Hospital, overseeing allied health, the rehab professions, and programs. So again, welcome. Just wanted to focus us in on our content today. Today we'll be looking at what tools are available to you, your teams, and families with respect to roles in pediatric eating, feeding, and swallowing services. And our objectives today are threefold. Number one, to share the collaborative practice toolkit created by this working group. Number two, to review the information and evidence around role clarity, which guided our development of role resources, including tools to assist teams to work through role clarity discussions. And number three, to give a broad overview of collaborative goal setting and share some resources around this topic. We are driven by the evidence-based fact that interprofessional collaborative teams are key to eating, feeding, swallowing, safety, and success. Just a quick note to let you know that we have provided training to introduce the new tools, clinical practice guide, and collaborative practice supports. We did have some training sessions in July, and today's session is the last of our fall sessions. The good news is that these sessions were recorded and they're posted on our PEAS website under courses and webinars for healthcare providers. If you would be interested in a certificate of attendance for this session, please email us at the email address you see on the screen, peas.project@ahs.ca. And just a couple of housekeeping items to get us going. If you have comments during the presentation, we welcome you to write them into the chat box. Please do take a moment to select all panelists and attendees if you want to make your comments publicly visible. Otherwise, it will just be us panelists who see those. And we also have time for dialogue and questions at the end of our session. And you can use the Q&A feature or the raise your hand feature to ask any questions at that time. I'm going to pass it over to Vanessa to give you an overview of the Pediatric Eating and Swallowing project.
Awesome. Thanks so much, Melanie. So I just get to share a few opening thoughts around the project scope and introduction to role clarity and communication. So the Pediatric Eating and Swallowing, or PEAS project, is a provincial quality improvement initiative with the purpose of developing a clinical pathway to standardize and improve care of children with a pediatric feeding disorder. For this phase of our project, our target population is children in the ambulatory care setting. And so we focus many of our resources on outpatient and community care, but they can very easily be adapted and applied to other care settings such as acute care. So at the outset of the project, we hosted 2 World Cafes in northern and southern Alberta to understand what was currently working and what wasn't working for the care of children with feeding and swallowing difficulties. So these results were very homogeneous. So regardless of where people lived across the province, we found that the most significant barrier to care was access to service and information. But the second very closest barrier to care was actually lack of role clarity and communication. And so these are just some of the examples from our World Cafes of the issues concerning families and care providers around role clarity and communication. So you can see there were some concerns around understanding who provides what service, that services often occur in silos, lack of goal setting, and lack of multidisciplinary care. So this is why the PEAS project has a multidisciplinary provincial working group involving leaders, healthcare providers, and families to develop tools and support improved role clarity. That is child and family centered. So we're looking forward to sharing these new tools with you today, and they can all be found on our new website, which is peas.ahs.ca. So today we'll be navigating you through those resources, and we also encourage you to watch those other presentations that Melanie mentioned about the other aspects of the website as well. And just one more plug, the website is mobile responsive, so it's a nice and friendly way to also share it with families. And speaking of families, we're really delighted to be able to have Mona Dhanda with us today. We actually have a few special guest speakers joining us, including Julie Evans and Carmen Lazarick from Alberta Health Services Health Professions Strategy and Practice, who will be introducing themselves shortly. But first, I just want to introduce you to Mona. So if you had the opportunity to attend our clinical practice guide session, Mona shared some of her family's story as it relates to the clinical aspects of care. And in this presentation, she's going to share her story as it relates to collaborative care, roles, and goal setting. So in addition to being a mom of a child with an eating, feeding, swallowing disorder, Mona is also an IT project manager for AHS, and we have had the privilege of working alongside her to launch our new PEAS website. Welcome, Mona.
Thanks. Thank you, Vanessa. So I'll start. This is a picture of my daughter, Isha. She's now 8 years old, but she did and still does have some challenges with feeding, swallowing, and getting the right nutrition. Let's go to the next slide. And then to give a little clinical background, Isha was full term. She was in distress, and so we had an emergency C-section. She was born with congenital heart failure. She had respiratory issues, and there was an unknown diagnosis of trisomy 21. And then here she's being taken to the Royal Alec, the NICU, where we spent about 4 weeks. And she was tube fed for the duration of our stay there. And then she was also diagnosed with permanent hearing loss there. Next slide, please. And then, so with her different diagnoses, we actually did feel very supported in the first year of her life. We didn't have any specific assistance with feeding, but we were connected to lots of different organizations like the Edmonton Down Syndrome Society, Connect Society for Children with Hearing Loss. We had home care, FSCD and ENT, all the different specialists. And we also had referrals to a couple programs at the Glenrose Hospital, which we actually declined because we thought we were sort of double dipping services at that time. We had 2 SLPs that we were seeing, one that assisted with forming sounds because of hearing loss, and one that assisted with her speech because of her diagnosis of Down syndrome. And although we knew she would have challenges with feeding and swallowing, we didn't really realize that we could seek intervention for that, nor did we know who we could ask for help or for assistance with feeding. And at that time, I actually didn't really know it was something that could be taught by a therapist. I thought it was just something that would just come naturally for her just a little later, just like, walking and all of her other types of gross motor skills. So now, if I had access to the PEAS site, I think there's this wonderful circle diagram for families. And it nicely outlines what the types of providers might play a role in Isha's life in terms of supporting her feeding. And it sort of clarifies, who I could go to speak to regarding, different issues we were having with feeding and swallowing. So I think this is something that would have been really valuable for us. And I bet if I had access to this, I would have kept those appointments at the Glenrose Hospital. So I have some regrets there. Next slide, please. And then Isha in her toddler years, she did progress. She was able to eat soft foods and then swallow whole foods if I covered them in yogurt or ice cream or something sweet and soft. But you can see from this picture, more food got on her face than in her mouth. And we did our best at that time, but I wish we had an access, like a resource like peas at that time. I think things would have been much better for our family, not just in terms of feeding, but in terms of access to self-care. There's an entire section dedicated to that provides lots of options for families experiencing stress and anxiety like we did. There is a section about funding. You know, everything we did was kind of through word of mouth. So we were seeking lots of private therapy, and we were paying, you know, between $135 to $180 per visit. And that causes a lot of anxiety, with 60% of that was coming out of pocket. And although we were very fortunate to afford some private therapy, it was still very confusing for us, as we'd have multiple clinicians from different organizations often providing us advice that might clash or kind of misalign with each other. And that just left us really confused with what to do. And like, you know, we were again left to choose with what we would implement and what we wouldn't. And at that time, we finally decided to seek intervention for her feeding. I realized I was just making the wrong choices. We stopped going to kids' birthday parties. We stopped going to family gatherings because the way I fed her was just, it was so cumbersome. It was so unusual. It was just so messy. And I hated comparing her to her peers. And then, you know, most of all, I just hated that unwanted advice I was getting from non-professionals whenever we would take her out. And so the next slide, please. We did apply, and we were approved to receive specialized services, and then everything changed for us. It was just awesome. We had a multidisciplinary team. We had a communication book where we shared our goals and quarterly reviews, and that involved the entire team. You know, and then when we would stray away from our goals, we could always come back to that document to remind ourselves of, you know, what our priorities were, because it's so easy to get swept up in the next thing. Our clinicians worked together. They shared our goals with each other, so we didn't waste, you know, some of our valuable time with the therapists on just communicating goals. And then I would say that feeding was the absolute largest group effort. It involved everybody. The SLP helped us with like the jaw alignment. Our OT worked with us on seating and holding utensils, and then our behavioral consultant worked on, you know, creating a positive environment for her and getting her excited to eat, rather than, you know, with the feelings of frustration and avoidance that we were previously experiencing. It also really brought us into the picture, so it really relied on us being consistent and putting what we learned into practice and building our confidence as her parents. And it really gave us the tools to be the parents I think that we wanted to be for her. Next slide, please. And so then, you know, things are a little different now with COVID-19. So we're doing online schooling with her. But previously, when we were transitioned to school, you know, we lost that multidisciplinary team. We're not invited to meet with the school therapists as much as I've tried to make it there. But, you know, the school sort of gets to decide whether she finishes lunch that day or she doesn't finish eating because needs to go for recess, or misses education time because she's, you know, needs to have a snack. And so, you know, that collaboration isn't there. So throughout our journey, you know, we've had a constantly evolving care team. We've experienced lots of different types of care, and we can strongly say that our family's been the most successful when we're part of a multidisciplinary team. I'm really excited that teams are focusing on collaboration, and then also making all the resources available to families on the PEAS website. So there's just so much transparency there. And I guess there's lots of things she still can't do right now, but I don't have as much anxiety and stress about it, because I've been through this multidisciplinary team and the process, and I know that I feel supported, and with the right assistance, there are things that I can do with the help of professionals like you to help her succeed with her feeding. So thank you.
Hello, everyone, and happy Allied Health Week. This is Julie Evans. I'm the practice director for Provincial Speech Language Pathology, and I have the pleasure of being on the leadership team for PEAS. I just want to say thank you, Mona, for sharing your journey and your learning along the way. It's a joy to get to know Isha through you, and it's so powerful for us to hear about the difference the way in which we approach our work makes in the lives of children and families. beyond the clinical influence and skills we bring. We really appreciate the opportunity to learn from you and from the many other parent advisors that are involved with PEAS. Isha and your family certainly provide inspiration for our work and also really make the work of all the clinicians on the line so rewarding. So thanks for sharing with us. I'm going to pass the mic now to Carmen Lazarick, Practice Director for Provincial Speech, I'm so used to saying that. Carmen, Practice Director, Provincial Occupational Therapy. Over to you.
Thanks so much, Julie. Thank you everyone for being here. So we know that collaborative practice enables providers to deliver our services in a way that results in better patient outcomes. A child and family first approach together with professional practice and action support collaborative practice. So we'll move into the next slide. The child and family are at the center of what we do, and I love this photo here on this slide. In fact, putting patients first is an AHS priority for all of us. Child and family first is an approach to care that focuses on the needs of the child and family, with healthcare providers working together to wrap around the child and family based on what their needs are. Regardless of one's role on the team, we all have a role in supporting the child and family. The strengths and needs of the child and family are the foundation for how we then individualize our approach to service delivery. This client-centered approach requires that we ask the child and their family to inform our practice, listening to the parents and to the whole family about what it is that they're looking for and seeking from services. We will later talk in this presentation about collaborative goal setting. The client-stated goals are what guides our intervention so that everything we do connects back to what the child and family need from us within any given episode of care. This is what drives collaborative practice, what matters most to the child and family. We start with that. After all, they come first. And Julie, over to you for this one, I think.
Hey, Julie, can you hear us?
If not, I'll just jump in.
Yeah, maybe go for it, Carmen. Thanks.
Okay, sure. Yep, no problem. Julie and I are just sharing back and forth here, but I'll jump in here. She might have had to get a different headset.
Hi, guys.
There's Julie.
So sorry about that. Yeah, my battery. I warned this, guys. My battery's a little weak, so.
Yeah, you've been on all day.
Do you want me to just pick up? Yeah. Okay. So Trish and Melanie asked me to talk a little bit about professional practice and just the importance and the knowledge that we place in the idea that providing excellent child and family-centered care really comes through excellence in professional practice. And so sometimes I think when we're thinking about practice, we believe that our individual clinical competencies and skills provide the foundation for professional practice. Indeed, they are essential. However, the literature is clear, and our interviews with clinicians and leaders have reinforced that quality person-centered care depends on the support of a strong system, team competencies, and the individual clinician. So those of you who know me well will know that I'm a big fan of the work of Laura-Lee Lingard, who talks a lot about team competence and the importance it has in patient safety in healthcare over and above the competency of individuals. So how our system enables clinicians and teams to work effectively is key to professional competence. And I think projects like PEAS are really good examples of the system's role in building excellent professional practice. How teams communicate and work together is crucial to safety and all aspects of quality. We just heard about the difference communication and collaboration made in the life of Isha and her family. So our individual competencies, including our collaborative competencies, are integrated with team competency and support systems to put professional practice in action. They're all dependent on one another. In preparing the resources that you're going to learn about today, clinicians work together to better understand the unique and overlapping contributions among team members and across disciplines. They were brave, really needing to challenge their own assumptions and those of others in their working group and within their profession. Regulatory colleges, AHS Interprofessional Regulatory Affairs, physicians, and multiple disciplines all came together to create a robust set of tools that we believe will help you put professional practice into action to address what matters to children and families.
Thanks so much, Julie and Carmen and Mona. And as Julie mentioned, it's been a privilege to be able to work with such a broad swath of wonderful people across AHS to develop these tools, and even more exciting to be able to present this week on Allied Health Week. So I'm going to just give us a little bit of an overview of the Collaborative Practice Toolkit that we've developed. We were so fortunate to have been able to partner with COACT to harness the power of the work completed through this Alberta Health Services initiative over the past few years. The COACT Collaborative Care Design provides a framework and an approach to implementing and sustaining collaborative care across the care continuum. The guiding principles and pillars underpinning all COACT collaborative care elements include patients first, or patient and family-centered care, high-performing teams, enabling our teams for success, and quality culture, better value and better experience for our patients and our team members. Having the advantage of adopting and adapting COACT's carefully created materials has been a huge boon to the PEAS project, and it really allows for continuity and consistency across care contexts and areas of practice. So to start off with, I wanted to show this graphic, and it really illustrates the goals of the PEAS project with respect to building strong collaborative care teams and enhancing coordination of care and communication within the eating, feeding, and swallowing area of practice. The feedback from the PEAS World Cafes indicated a disjointed or siloed current state, with teams separated by their discipline, perhaps by their geographical area, or even by their clinical program within the same site. That's kind of illustrated on the left side of the screen. Our goal is to provide teams with information and tools to help build care teams that are centered around the child and family and operating under a shared goal of best patient care with fluid communication between all members of the team. To promote interprofessional care, bringing together the unique perspectives of varied disciplines, regardless of whether people work in co-located teams or are geographically spread out, as you'll see on the right side of the graphic. As we mentioned, we had the benefit of working together with COACT to develop collaborative care elements specifically for PEAS, which have become part of the larger PEAS Rules Handbook. The 4 resource bundles, as you'll see here on the slide, included in our handbook, are listed on the slide here and are designed to support the operationalization of the principles of collaborative care. They are all interdependent and they're applicable across the care continuum. We'll talk a little bit more about those bundles. And instead of digging into each element individually during this presentation and taking our time that way, I will show you where they're located on the PEAS website, and I would encourage you to take the time to review each element yourselves. So on the website, in the For Providers section, you will see collaborative practice listed along the left list of contents. Simply click on collaborative practice and then read more under the collaborative care primers and resources section. The 4 elements of team charter, collaborative care team, assignment of care, and collaborative care leadership are accessible here as printable PDF documents. We'd like to share a bit more specifically about developing a team charter, as we found this to be very valuable and an edifying process for any team to undertake, really. Across Alberta Health Services, teams have found that developing a team charter facilitates ownership of collaborative working relationships in the care environment. It enables the team to function in an empowered manner, provides a link between the team's goals and AHS's overarching mission, vision, values, and goals. A team charter is a collaboratively developed description of the team members' responsibilities, accountabilities, working relationships in the care environment. It defines the purpose of the team's values, the operating rules, and accountabilities. It provides the scope and approach to collaboration, outlines expectations, behaviors, and commitments. It also provides an agreed upon process to resolve interprofessional conflict if it does arise. Creation of a team charter really needs to be initiated by all team members, including operational and practice leads. And it's a living document that should be revisited on a regular basis when new team members are joining, or when there are changes in the practice setting, or even if there aren't changes. We plan to facilitate time for teams to develop a team charter at our upcoming Innovation Learning Collaborative Orientation session on November 25th, and we hope that we will see many of you there. The PEAS website will give you access to a team charter primer or info sheet. A team charter development guide is very robust, developed by COACT. Also templates and some examples of charters developed by existing pediatric eating and swallowing teams, such as the one you see here. This one is an example of a charter developed by one of the eating, feeding, swallowing teams here at Alberta Children's Hospital. We worked through this process with a number of our teams, and it's really been gratifying and productive, and has provided the opportunity for a shared reference point during all role-related discussions amongst team members. On the website, additional collaborative practice primers and resources can be found just below the team charter, and they include the collaborative care team, assignment of care, and collaborative care leadership elements. As you'll see when you visit the website, each of these materials are brief, just 2 pages, and they include practical concepts, suggestions, and steps to implement and enhance collaborative practice. We would encourage you to review them with an eye to how these key principles of collaborative practice may be put into place in your context to support practice, process, and quality care, and ultimately focus on what's best for our patients. That's our toolkit, our collaborative practice toolkit, and I'm going to pass it over to Tricia now.
Hey, thanks, Melanie, and happy Allied Health Week wishes to everybody. Just going back to the original purpose of the Provincial project, lack of health provider role clarity was one of the top concerns presented by families at the World Cafe meetings that were held fall of 2018. The CADA evidence review in 2017 provides clear direction that a team approach is required to best support safe feeding and swallowing assessment and care coordination, as dysphagia is considered a complex health issue. We will cover your role as operational or PPL leads in the use of roles, and of course as frontline staff as well. The PEAS Roles and Implementation Working Group initially tackled review of role resources supports for healthcare providers. Once the role resources were completed for healthcare providers, the resources were adapted for families to utilize in order to support the family journey related to their child's eating, feeding, and swallowing. So departments, units, teams will have access to these resources to have conversations about services to babies, children, and families. For healthcare providers, you'll find the AHS developed PEAS role descriptors and tasks within full scope on the new website under collaborative practice. These tools are, I see that, sorry, I might be on the, oh, there we go. These tools are intended to be used together as a package where you find specifics related to role descriptors such as scope of disciplines and overview of roles. In addition, the tasks for each discipline are a comprehensive list for an individual working at full scope of practice. But just keep in mind that not every individual representing a discipline will be ready to work at full scope. We just wanted to make sure that each health discipline college or regulatory body confirmed each discipline's maximum scope. As PEAS is an advanced area of practice, we acknowledge that individual healthcare providers may seek additional training and mentoring to work at full scope. These tools are listed, are used by by everyone on the team, right? Practice leads, operational leads, and frontline to be adapted for your specific team. Together with families, clinicians, AHS Health Profession Strategy and Practice, AHS COACT, and professional colleges, the PEACE project has developed the roles and descriptors and tasks within full scope for healthcare providers so that clinicians have an adaptable tool to highlight, communicate, and clarify overlaps and gaps within a team. Also promoting that interprofessional care with everyone's unique perspectives, focusing care team members on their collective team competence to address child and family-centered goals for eating, feeding, swallowing, as was highlighted earlier, and provide a tool to identify and cover gaps in service. A part of the roles, descriptors, and tasks within full scope tools, we've developed a diagram that addresses roles as shown on the left. It outlines multiple and different care providers, such as the dietitian, OT, SLP, psychologist, physician, nurse practitioner, lactation consultants, and other disciplines, their different training and skills, and of course, that imperative and central role of the family in the interdisciplinary care. And you'll notice that the colors and the lines they meld or they blur just because, right, the scope of every discipline, there are times of overlap. And when we look at the triangle on the right, we've clarified that individual scope of practice is determined by ministerial regulation, professional regulation, employer policy, and individual competence. So just for an example, starting with Medicine Hat Regional Hospital, quite a few years ago, we had some conversations as team members, and it was important to staff and managers that we had better clarity on roles based on confusion. So we looked at the sustainability of this service when providers move from unit to unit or were taking on different positions. Every time we review a team's functioning on different units and sites, we look at roles. This then allows that respect for the various roles in our disciplines. And the work can be complicated and touchy. We noticed that when we went through the process, but it really depends on the team's composition, and it's an important task to undertake. And actually our refresh, we're looking forward to that coming up here at the end of November. We all needed to review our scope of practice and then look at overlaps to determine what we were comfortable doing as a team. And we learned a lot together. There were aspects of service that we discovered to better serve the family, such as using the hospital education team, and wayfinding was improved because we all had a better understanding of where to transition a child and family. So whether that be transitioning from acute care to community, outpatient, public health, allied health. And we wanted to discover who is the most appropriate person to do a task on the team for the safety of the baby or child. Each team documents their decisions on the chart for transparency and clarity, and it built our understanding of when to involve another discipline based on our conversations as a team. So after reaching consensus on the discipline functions at Medicine Hat Regional, team members and managers did express better satisfaction with how we functioned as a team to serve babies, children, and families. And over to Mel.
Thanks, Tricia. We have an example from Alberta Children's Hospital as well. At our site, an opportunity was identified to ensure that a full interdisciplinary feeding team is consistently available to infants and families in the neonatal intensive care unit here at ACH, and to enhance coordination of care around eating, feeding, and swallowing. This is such a key issue for these tiny little neonates. We worked to ensure that there was FTE available from each of the disciplines identified as key players in feeding. So that included nursing, neonatology, dietetics, lactation consultancy, occupational therapy, speech language pathology, and social work, not to mention a focus on highlighting the parents as expert team members, of course. So weekly feeding rounds were initiated, which has allowed real life experience to guide role clarity and collaboration between team members, really flesh out those roles. Feeding plans are being made and are agreed upon by the family and interdisciplinary team after discussion and input. Feedback from the team is that service has become much better coordinated, care is shared and more efficient, the level of service availability has improved significantly, and in some cases length of stay is shorter, which is a major win for these families. From the nurse practitioner who spearheaded this work and continues to provide leadership to this team, she sent us a quote. She said, "This work has brought the team to a point where we are cohesive. It's amazing and so important for our babes and families." Thanks for letting me share that.
Okay. So in addition to their roles, descriptors, and tasks within full scope, we've worked with AHS Interprofessional Regulatory Affairs to create a frequently asked questions document that can be found in the additional resources section, as Vanessa's showing, and then under the collaborative practice section here. In Alberta, healthcare professionals are required to follow provincial healthcare laws, legislation and regulation, professional college standards, employer governance, and self-regulation when they provide healthcare services to patients and clients. These requirements are primarily in place to ensure that Albertans receive quality, safe healthcare service. Healthcare practitioners from different disciplines may have similarities in their education and training, but despite these parallels, the role of each each profession remains distinct as defined by professional practice statements, regulatory college standards of practice, and competencies that are unique to each discipline. So first, with restricted activities, the Government Organizational Act contains a master list of healthcare activities that are restricted. These activities are restricted because they are considered to be risky and require specific education, training, and competence. Secondly, the term diagnose is not a restricted activity. Some professions have it within their scope of practice in their practice statements, college standards, and competency profile to diagnose, and others do not. And the dictionary defines diagnosis as to recognize and name the exact character of a disease or problem. Third, the Health Professions Act is the framework document that provides common provisions that apply to all regulatory colleges and schedules that apply to specific professional colleges. All regulatory or regulated healthcare professionals have profession-specific regulations that provide governance for the profession. These regulations provide direction for what restricted activities the profession is authorized to perform. With collaborative competence, when working in an interprofessional team or a collaborative care environment where different regulated professionals care for the same patient, each regulated member works under their own legislative, regulatory, and college standards and remains individually accountable for the care. And lastly, the role of AHS for directing how professions practice. AHS is accountable to uphold Canadian and provincial legislation, regulation, and accreditation. AHS develops process, resource, and tools that support regulated professionals to practice safely and provide the quality care. AHS strategies, values, and competency statements help describe the expectations for staff working at AHS. AHS does have the authority to decide on the role of a regulated professional in their position, but may not insist that a profession perform authorized restricted activities that are outside their professional scope. And again, that's within the Government Organizational Act. So when you look at the screen here, you'll see the additional resources page. And just to navigate that, just gonna open up my screen here so that I can see a bit better. You'll see a number of resources, some great videos available that have been vetted by the working group. And again, you can take a look at your leisure at these additional resources. We have resources also for family members who are an important and again, imperative role of the care team. And thanks again to Mona for the initial opening to the session today to remind us, the family is, as indicated in the literature, has that integral role, as well as the COAC principles highlight this, and health change methodology as endorsed by Alberta Health Services. There's also information about self-care and involving people in the community, such as school personnel, friends, other family members, as well as information about finding a support network, including links to peer support networks for families whose children have an eating, feeding, swallowing disorder. Great. So just showing some of the resources there. Under the families section, we also have information for families about their care team and various roles that each provider might have. This circle diagram is similar to the one for healthcare providers, but again, that emphasis on the family lens. Finally, in the care coordination section, there are expandable questions for families to explore. And I'm just going to open that up here so I can see it a little bit better. So Vanessa's just navigating to one, so such as who do I talk to? Then it will open up and talk about food preferences, emergency health planning, and changes in the child's development. Just a few examples. Okay, and over to Carmen. Thank you.
Thanks so much, Tricia. Okay, and Vanessa, just to let you know, my internet's having a little bit of issues, so I'm hoping that I'm going to stay clear and connected.
Sounds good.
Otherwise, I'll be back in a moment if anything happens. All right, so thank you so much. So there's been some significant provincial work over the last couple of years related to collaborative goal setting. And I know many of you on the line are already experts in this, but I think we can always reflect on how we improve and think deeper about how we actually incorporate collaborative goal setting principles into our practice. So the recent successes are because of your work locally and in your areas and zones as participants in provincial work like the PEAS project. So clinicians and teams intentionally engage clients and families in a shared decision-making process resulting in functional client-centered goals. The client is the expert on their values, their preferences, what motivates them, whereas the provider is the expert on the condition and the rehabilitation process. So this is really a two-way relationship, a partnership in terms of goal setting. Our role is to facilitate this journey, the journey towards the goal, towards seeking out that same goal or the same shared understanding of what the goals are, and really seeking out to understand what the client and family are telling us in terms of what their motivations are or what motivates them, what they desire, and really that, again, that shared understanding of the goal. So what is collaborative goal setting and why do we do it? Collaborative goal setting improves client outcomes. When clients and families are actively involved in making decisions about their goals, their engagement, satisfaction, and motivation improves. In practice, this translates to improved clinical outcomes, greater commitment in rehabilitation, improved self-management, and fewer no-shows and fewer cancellations, as well as fewer readmissions after discharge, either likely back to rehabilitation, for example. So we really see that self-management piece allows people to carry on with their lives, manage themselves, and manage their conditions more successfully. And it has been and still is an organizational priority, as I mentioned at the top. The patient-first strategy and patient-centered care are expectations in Alberta Health Services. Collaborative goal setting is an explicit way to ensure that we are asking children and families what matters to you and collaborating with them in order to deliver our services. So this sounds reasonable, I'm sure, to everyone and evidence-based, but how do we do this? Many teams do set goals as part of their process, but may not be doing so in a consistent collaborative way. So I'd like to spend another couple of minutes for us to reflect further on evidence-informed goal setting and tools that we can really start to apply in our practice today. Goals should be recognizable to the child and family. So the child and family should be able to say, yes, that's what's important to me right now. And they should feel that they really have some ownership, that they own their goals. So it's not my goal as an occupational therapist, for example, that the child will be able to maintain trunk control or use a spoon to eat yogurt. But instead, it might be that the child and family goal is to be able to eat breakfast together consistently as a family. There might be some actions that the OT or another discipline will want to apply in the treatment plan, and we'll see that later when we go through an example. And to be able to monitor progress and use sort of more that SMART type of approach to be able to identify those discipline-specific or measurable actions and tasks that we want to do as part of the treatment plan. But the overarching goal is what we elicited from the child and family and is based on what matters to them. Goals are therefore not pre-configured. We do not know what the child and family's goals are based on their health condition or even their presenting symptoms and functional issues. We don't know what the goals are until we engage in a shared decision-making process and conversation with them to establish what matters most to them right now. So we've covered that why behind collaborative goal setting. Now let's focus a little bit more on how this is done. And how do we know if we are applying an evidence-informed approach to goal setting? There are 4 principles to keep in mind. Collaborative goal setting involves shared decision-making. The goals are client-centered and client-stated. The goals drive intervention, and the goals are documented. It is through a shared decision-making process that we engage the child and family in establishing their goals, and that the goals we land on are indeed client-centered and that they can drive intervention and that they can be clearly documented. So my final slides will focus on the clinical documentation of collaborative goals. And while Connect Care is not the focus of today's presentation, it's important to note that we have built multidisciplinary tools in Connect Care, and this will support collaborative goal setting in practice and allows for documentation of goals and treatment plans. And these are tools that we want to improve and incorporate into practice over time. Currently in Connect Care, providers have access to an inpatient collaborative goals and treatment plan flow sheet where they can document the client-stated goals and the tasks associated with working towards each goal. And in the ambulatory platform or environment, providers can use the treatment planning activity for easy documentation of goals and tasks. In both cases, there's the ability to document also the progression of the tasks and the goals. So that gives an example, just a quick little snapshot of what will come for many of us in terms of Connect Care. Until all programs and services have transitioned to Connect Care, there are other tools that support practice in current documentation systems. A great example of this has been adapted for use across the PEAS services and programs and is the goal wheel, something we refer to as the goal wheel for those not already familiar with it. The center of the goal wheel is the client-centered goal statement. Now there you see an example of the form. And so in the center, you see the client-centered goal statement, and the shared decision-making process is used to identify the actions or tasks that will enable progress towards that goal. So in the next slide, we have an example, and I think that providers may find it helpful to review an example of what a completed goal wheel looks like and what kind of content might be in there. Of course, everyone will be different, but this, if it's newer to practice or if this particular form is not something you're currently using, it's helpful to look at an example. So Mona, who's on the line with us today, collaborated with an occupational therapist to complete a goal wheel with a focus on an overarching goal related to meal times. So I'm going to pass it over to Mona to maybe just focus on what's in the center there, the stated goal that you came up with, Mona. And if you just would speak to that for a moment, and then I'll just take it away after that.
Sure. So we did this exercise with Liz, and thought it was a really great exercise. The goal setting we did previously, you know, it was pages and pages, but I like this particular one because I have one goal, and sort of it was my thoughts condensed, and I liked how Liz was able to kind of capture what I was saying in one succinct statement. What I also like about this is that this is something like I could just pin up on my fridge, for example, and it's not just the onus is on me. My partner and all my my daughter's siblings could look at this and say like, well, how can we help to contribute toward this goal, this one simple goal that's easy to understand and easy to measure. And so I even reading this, I did sort of tear up when we did this, even though I was doing this, you know, 5 years, you know, ago. And Liz really sort of helped me to say like, previously my goal would have been like, I want Isha to be able to eat at a table with a fork and a knife and a spoon. And then when she heard what I said, that really wasn't what I wanted. It was really more about me, that I wanted the confidence to be able to take her out. And right now she's 8 and actually she really can't use utensils. And I realized like, that's just not important to us. What's important is that I've got tools that I can use to help her sit and have a meal and sit appropriately and be part of family gatherings and things. So I really do love this format. And also I just want to say that I like how there's some really short-term goals that I could have tasks I just quickly could have done. I could do them with no intervention, but you know, some long-term ones such as like consider connecting with a psychologist, which is something I couldn't do myself. So I just like that there's a variety of different things that I can attempt to do on my own with this particular format.
Great, Mona, thank you so much. Yeah, that's really, I think, really helpful for us to hear from you, the experience and how this could be used in your family and in your life at the time when you would have been setting this type of goal. So, and I like also how you pointed out that Liz, as the occupational therapist working with you on this, was obviously really actively listening and engaging with you and getting that shared understanding of what it is that you were actually wanting to work towards. So that's really the center of the goal wheel, is an overarching statement, and really could have quotes around it because often it really is coming directly from a family member or from the child themselves, depending on their age, about what that overarching goal is. And then the actions or tasks around the outside in the boxes around the circle are where we would then develop more of those specific tasks and actions that will be taken either by the client or family themselves or jointly with the provider, or in some cases maybe some identified tasks that the provider will go away and act upon and then bring it back to the client. So I think that's really helpful for us to see how those actions and tasks and the shared understanding of the overall goal process can really be used in a documentation format to work towards that evidence-informed approach to collaborative goal setting. So just go to the next slide there. And I just wanted to mention that the PEAS webpage provides further information about setting goals with children and families. Strategies such as using SMART goals can be applied, and further tips about tracking progress on goals can also be found here. And the green links at the bottom of this page take you to the additional practice supports that are focused on collaborative practice and collaborative goal setting. I'll pause there. Thank you.
Thanks, Carmen. Thanks, Mona. So you can contact PEAS by looking at just using this email, but anytime you have questions or additional tools or handouts that you would like reviewed by PEAS leadership, they would be reviewed and then posted on the website. Sorry, just one sec here. And also you can consider subscribing to upcoming news and events through the website as well, and subscribing to the PEAS community of practice. So this brings us to a close. Just giving you a heads up that questions, comments can come through the comment button, but also we have one additional slides here for you. And also we, as chairs for the PEAS Collaborative Practice and Roles Working Group, Melanie, Vanessa, and I wanted to reiterate our gratitude to the working group members. We will highlight right away here. The PEAS Steering Committee, Julie's on that group, has provided us with great leadership and guidance in our journey, and we're thankful for the steadfast clarity and purpose of the work. Thank you to PEAS leadership team and, of course, the family advisors, Mona on the call, who have supported the purpose and vision of this work, just like a North Star. So you can consider completing the 5-minute survey that will come out after this section. And thanks again, everyone.
Thank you. Yes, thanks to all of working group members and also to those of you on the line who supported their participation, potentially providing some relief while they were off at a meeting. And this has just been an amazing project. The quality and depth of resources you've created for us is astounding. And Mona, the website is fabulous. You must be so proud. Thank you. Before we close today, we would just like to take a moment to remember Wendy Johansson, who was part of the Roles and Implementation Working Group. Wendy was a highly skilled and compassionate clinician who made a real difference in the lives of so many infants, children, and their families. Across the healthcare system, we relied on her. I relied on her for her clinical expertise and just truly passionate leadership in the area of pediatric eating and swallowing. Wendy was a force within the PEAS project, touching all aspects of service improvement. She had a clear vision for our ability to create well-coordinated and excellent services for infants, children, and families. Wendy passed away on July 21st, 2020. Her legacy lives on. Through our work to improve services for children and families, we'll continue to honor her always. Let's take a moment now to remember Wendy. And I would just like to say on behalf of the PEAS leadership, I want to express our condolences to all of Wendy's colleagues, friends, and loved ones. Thanks you guys so much for taking a moment for Wendy. And we're going to close here, but please do let us know if you have questions, be in touch, and we'll be on the line for a couple of minutes too if anyone wants to put something in the chat. Take care, everyone. Thanks and goodbye.
Thanks for your comment there, Rebecca. Yeah, and if anyone else wants to ask a question, you can also raise your hand and we can unmute you too if that's easier. Okay, well, awesome. I think we'll call it a wrap then. Thanks, everyone. Great job, Julie, Tricia, Carmen, Melanie, Mona.
Mona, especially, so awesome to have you here. Thank you very much.
Totally. Thank you, Mona.
Thank you, Mona.
Oh, and Dana has a question here. I think we could all say resounding yes. Would you encourage community practice teams outside of AHS to also use team charters? I really love that.
Absolutely.
Yeah. You could even get together and do one with people from within AHS.
Yes.
How crazy would that be?
Concept of extending,
That's right.
right?
Absolutely. Yeah, it's a great question. We've seen already the value of using these resources with teams that are not working in feeding and swallowing. So it's great work.
Okay.
Bye, guys. Thank you.
Thanks, everyone. Take good
Thanks, everyone.
care.
Bye.
Bye.